This is Dr. Michael Cryer here, CVIS 2025, your social media ambassador. I'm here with Dr. Mark Bieniarz. Dr. Bieniarz, if you don't mind me asking, I know you practice out in New Mexico and you get referrals from sometimes other states. A lot of places are underserved in terms of your referral patterns. How do you guys handle the unique logistical challenges that come along with that, especially when structural procedures require so much evaluation before and after they're performed?
So we've decided to really employ televideo in our workup for patients that are very remote and initially just see what kind of symptoms they're having and see if they need a structural intervention at that point or if we can wait and have them followed by their local doctor. One of the main problems is access to care, and we tend to see disease that's progressed extremely far prior to the patient engaging with a physician. But what we want to avoid is patients traveling over 3, 4, 5-hour distances and for one consultation. So we try and set up all diagnostics and then an appointment with a surgeon and maybe even a TAVR or a structural intervention after that point if they've had a local echo done that I can review. And it speaks to the benefit of technology with DICOM transfer systems. It's very, very important that we get away from 1980s and 90s technology of just sending CDs and actually have real DICOM transfer that's advanced. So that helps remote programs like ours.
Yeah, those are great points. You guys have a very successful percutaneous VA ECMO program. Can you give some insights into how and what makes your program so successful?
So what we decided to do was gain control of the whole approach to shock through being able to offer 24/7 care for shock patients coming from the entire state and the surrounding area. Shock is very difficult to diagnose exactly what the phenotype of the shock is right at first, just hearing about the patient. But what we do is we have, alongside of our interventional call, we'll do shock call. And so the shock call is multidisciplinary, and we have everyone on the phone to talk about the status of the patient. People around the state, because of educational programs, have learned to check lactates to assess as much as they can evidence of end organ failure as a downstream effect of shock, and then we'll bring the patient in and try and assign them the right bed in the right facility, and then ultimately sometimes if the patient does not have massive comorbidities, looks like their shock can be reversed, we'll do a right heart cath emergently in order to diagnose what kind of shock, and then we can offer a vast array of appropriate support devices for the right heart or the left heart or both. And so it doesn't stop at VA ECMO. We're able to offer biventricular support. We're able to offer isolated right ventricular support, VV ECMO, or just right ventricular support with a Protec or an RV Impella. And what we've seen as we have an approach to shock that's algorithm based and predictable, where it can be reproduced across any interventional cardiologist, our outcomes then reflect the other programs that have the same shock program. So our outcomes are totally reflective of Innova and Henry Ford that have implemented the same types of shock algorithms. And that's the benefit of actually having predictable care. And then the interventional cardiologist follows that patient through continually assessing for any changes or the need to escalate. And so we also have a program of early escalation and engagement with the surgeons to be able to place a 5.5 or escalate from an Impella CP to VA ECMO or a 5.5, depending on their right heart numbers. So it's just all standardized care, algorithm-based care that then benefits the patients and reduces their in-hospital mortality.
Excellent, that's great. If you don't mind me asking you one more question, what career advice do you have for early interventional and structural cardiologists?
It's a great question. I would say, so I wake up every morning really excited by what I do. I've been an interventional cardiologist for 17 years now, and I love going to work. I love being at home with my family, but I love going to work too. And so I think that having that balance between what you do outside of work and what you do at work, that's going to make you the happiest. And realizing that your career is going to take many, many different turns, and to continue to be interested and to continue to serve people, because ultimately this is about serving and treating people how you'd want to be treated.
Yeah. Thank you, Dr. Bieniarz.